Hello and welcome to the Care Partner Training at Insight Memory Care Center. Today we're talking about managing Lewy body dementia. Our mission is to provide specialized care, support, and education for individuals in all stages of memory and cognitive impairment, their partners, and the community. Our vision, a community where those living with memory or cognitive impairment and their care partners can achieve the highest quality of life. We are a leader in dementia care in Northern Virginia. We're happy to say that this is our 40th anniversary this year, helping families on their dementia journey. We provide care that is specialized adult day programs for people in all stages of their dementia journey. We build connections and relationships in supporting care partners on their journey, and with our creativity of dementia experts sharing their knowledge and resources, because every journey is unique. So I would like to introduce today for our presentation, Julia Wood. She is from the Lewy Body Association and is the Director of Professional and Community Education. She is an occupational therapist who specializes in the treatment of individuals with Parkinson's disease and neurological movement disorders. She's the Director of Professional Community Education, she contracts with the University of Pennsylvania Parkinson's Disease and Movement Disorder of Excellence to develop community engagement programs. She serves as the faculty for the Parkinson's Foundation team training for Parkinson's program and is a certification and training faculty for the LSVT BIG program. She serves on the Parkinson's Foundation Rehab Medicine Task Force and on the World Parkinson's Congress Comprehensive Care Subcommittee for Barcelona in 2023. Welcome, Julia.
And Melissa, thanks so much for having me. And thank you for the introduction. Welcome, everyone. Thank you all for joining. If it's okay, Melissa, I'll go ahead and share my screen. Or you got anything else?
No, I just want to tell everyone, if you have any questions, I apologize. I'll get her on the screen in 1 second. If you guys have any questions, please put them in the Q&A and I will answer them. And we will get working on that. So you are all set.
Excellent. All right. Thanks so much. Oh, there we go. You're still sharing screen, so I have to wait. All right. So let me try this again. Here we go. All right. So thank you all for having me back. I know Insight Memory Care is a really great supporter of the Lewy Body Dementia Association, and they frequently have myself or my colleague Brandy Hackett on, and I just really want to comment to how much I appreciate the support and collaboration with Melissa and other partners as well. So let me get started here. All right, that looks better. So as Melissa mentioned, my name is Julia Wood. I'm the Director of Professional and Community Education at the Lewy Body Dementia Association. And today we're going to focus in and talk a little bit more on managing Lewy body dementia. And it's important to note that, as we get into the complexities of the disease, you'll probably understand how I'm really touching the iceberg, or just kind of on the tip of the iceberg here as far as management in a 1 hour topic, but I hope to really give you a broad overview. But please know we'll talk at the end too about how you can reach out to us at LBDA if you have more questions or kind of need a little bit more guidance or resource. Okay. So I'm not going to read these disclosures to you at all, but this is really meant, the most important thing to realize is this is meant for educational purposes. We're not trying to replace guidance of any healthcare provider or medical professional, but we're just really trying to provide education and information for you. All right, so I just want to start out, I think, to talk about anything, you have to define it. And we have to really understand and make sure that we're all on the same playing field here. But I think probably at this point, everybody understands that dementia is really an umbrella term that describes a range of symptoms that are associated with cognitive impairment. But it's part or parcel, usually, of a lot of different types of diseases. The most common, of course, is Alzheimer's disease. And we're going to actually talk about how Lewy is not like Alzheimer's in some ways that it is. And that makes up about 50 to 75%, you'll notice there, of cases with Alzheimer's disease. Vascular dementia is next, but vascular dementia, that's usually after a stroke or some type of ischemic event. That's not considered a progressive dementia. So, Lewy body dementia is actually the second most common type of progressive dementia after Alzheimer's. And you'll notice there that it's estimated it makes up about 10 to 25% of cases in the United States. And then frontotemporal dementia, which we've been hearing a little bit more about with Bruce Willis, you'll notice is a little less there. So, it's definitely not a rare disease. Some statistics I want to throw in here. It's the most misdiagnosed form of dementia. So it's very common for people to think they have Alzheimer's or Parkinson's disease or a different condition and actually have Lewy. Sometimes people, if you've seen Spark, which we'll be showing later this year with Insight, realize that he died without a diagnosis. He did not know he had Lewy. They found that out upon autopsy. In that last diagram, it showed too, we think there's about 1.4 million Americans affected. These are adults, mostly over the age of 50. I already talked about how it's the second most common cause of dementia. And I think this is really important to note that studies indicate that it's the most expensive form of dementia. So as we get into some of the complexities of the symptoms today and how complicated the management can be, I think you can really see where this can be very costly to families and very costly a condition to try to manage. So, to set the stage here, Lewy body dementia is also an umbrella term. We just have all these umbrellas out in the dementia world here. So, up in the top left hand corner, you'll notice that little brown looking circle inside of that cell. That is a Lewy body, and they're named after the neurologist who discovered them. It actually would be Dr. Frederick Levy. He was German, but we say Lewy. And so it's like a clump of a misfolded protein called alpha synuclein. And that protein clumps and misfolds and it kind of clogs up the neurons and the signals that they're trying to send through the brain. And so that is really what we think to be, anyway, the pathology. That's really the biology of this disease is these misfolded clumps of alpha synuclein, where with Alzheimer's, you have those amyloid clumps, right? And those tau tangles, so different proteins involved. So you'll notice here, Lewy body includes two different types of dementia. Parkinson's disease dementia on your left-hand side of your screen and dementia with Lewy bodies there on the right-hand side of your screen. And you'll notice in the case of Parkinson's disease dementia, people have already had Parkinson's disease. And we know that around 50 to 80% of people with Parkinson's go on to develop dementia. But this happens years after their Parkinsonism or the slowness, the shakiness, the stiffness, those changes to movement happen. Now, what's interesting is in the case of dementia with Lewy bodies, the dementia starts first or at the same time of the Parkinsonism or within 1 year. So we call it the 1 year rule. And what's interesting too is for dementia with Lewy bodies, some individuals don't really develop much Parkinsonism or those movement changes at all. The changes stay more cognitive, more psychiatric, more of the non-motor type of symptoms. So you can kind of think of it like a chicken or egg, right? If the Parkinson's came first, it's Parkinson's disease dementia. If the dementia comes first, it's dementia with Lewy bodies. They share the same biology, though. They share that same misfolded protein, those clumps of Lewy in the brain. So, how does it differ from Alzheimer's? Well, we know with Alzheimer's, there's that amnestic presentation often, or those changes to memory. It also affects the ability to learn new information or store new information. There's gradual changes to thinking and memory, and there may be some physical symptoms with Alzheimer's, but they typically happen much later in the stages of the disease. In the case of Lewy body dementia, memory is mostly spared in the beginning. So this is why it's often missed. Fluctuating abilities, though, to think and remember really are characteristic or hallmark. And so this kind of up and down that we'll talk about later and these changes to cognitive ability. We typically see more issues with attention, and that can sometimes look like a memory problem, right? If I'm not paying attention when you introduce yourself, I may not remember your name. It's not really that my memory was impaired, I wasn't paying attention. We also see a lot of issues with problem solving and reasoning. And the physical symptoms, so those movement changes we talked about, may be present at all stages for people with Lewy. And also, this can include hallucinations and REM sleep behavior disorder. And often those are some of the early symptoms of the disease, not later on. So, some differences here, right? So with these two graphs, and I think this says so much. The top bar graphs, that strip of bar graphs, those are all people with Alzheimer's disease. And they took a whole battery. Each of those little blocks on the bar graph is a different type of cognitive assessment. Now, on the bottom, people with dementia with Lewy bodies took the same assessments and when they compare them. So take a second and look at the two bar graphs and just think to yourself, are they the same? Are they different? Or do they look almost opposite? For me, when I look at them, I feel they're almost opposite. So if we start at the far left with that black bar, you'll see how it says dementia, or it has DRS below it. That's the dementia rating scale. That's a global measure of cognition. And you notice it's the same for the people with Alzheimer's disease and the people with DLB. They did pretty much the same on that assessment. But that's where the similarity ends. Those three red bars, when you move to the right, those are measures of memory. So you notice how low those scores are for people with Alzheimer's. Down at the bottom are folks with Lewy, doing pretty well in the memory domain. You move a little more to the right with those bright green bars, that's language. So you notice how there's language changes for both, definitely more impacted in Alzheimer's though. But notice how the ones that are stronger for Lewy at the bottom are lower for Alzheimer's and vice versa. Then moving to the left, you see, or sorry, to the right, still you see that yellow, those yellow boxes. That's attention and executive function. Look how much higher those scores are for Alzheimer's at the top compared to Lewy at the bottom. And then the same thing with visuospatial function here. The visuospatial function, which we'll talk a little bit about, much higher for people with Alzheimer's than for Lewy. So I point this out in that sometimes if you're trying to find services, you might be going to types of memory care, or maybe you get a therapist or a home health aide who has all this experience with Alzheimer's, and then it seems like they have no idea what to do with your loved one with Lewy. That could be very common because the two, when you're dealing with the cognition of the two, they're very, very different. And you can also see how that global rating scale on the side with the similar score, you can see where if that's all that happens in like a primary care doctor's office, if they just do like a global scale of cognition, they're likely going to miss it. So I'm not going to get a lot into diagnosis today, but really important. If you have any suspicion, you haven't been diagnosed, not often diagnosed by primary care, really need to see neurologists, maybe even a movement disorder specialist, because the diagnosis can be very tricky. So we're going to be focusing on management today, but I just wanted to give a little nod to how complicated the diagnosis can be because the two are similar, but also very different. So the prognosis, this is where it's similar. Like Alzheimer's, it can be 2 to 20 years. It can vary really widely. And the factors that affect this prognosis seem to be overall wellness. So, how much does someone exercise? How socially engaged are they? What things do they do to really take care of their overall health? Diet, nutrition, sleep is a big issue. Also, other medical conditions. So, if there's a lot of comorbidities, diabetes, maybe heart conditions, cancer history, that can also affect the prognosis. And then the quality of clinical care we see for people with Lewy. If that care is really low and really poor, that also affects prognosis. So the recent data, the average life expectancy, they think is around 4 to 7 years from the time diagnostic symptoms appear. Now, keep in mind, like I said, that range though is much wider. So this might be what's average, but it's not everybody's story. So I don't want everyone here to think my loved ones, I'm like, they've had it 3 years now. Oh no, this is just one range. We recently had a really great webinar too with a doctor from the University of Florida talking about what to expect end of life. And so if you have more questions and curiosity about that, that's a great webinar to watch, and I can help you guys find that resource. So let's get into management, right? So the current treatment strategy, is really the focus is on improving quality of life. Unfortunately, there are no current treatments available to stop the progression of the disease or to cure the disease. But I think it's important to note there's some studies going on that LBDA is actually involved in where we're looking at some agents that may modify the disease. So we don't really know what this is going to look like in the future. And I think there's a lot of progress happening. But the thing to note, and this is what we're going to be focusing on today, many of the symptoms can be managed or reduced with medications and other therapies. So sometimes people will say, even doctors, well, why does it matter if they have a diagnosis? What does it matter if they have Lewy or have Alzheimer's? And as you're going to see today, there can be some very dangerous drugs and treatments that we use for types of dementia and for Alzheimer's that we should not use for Lewy. And also, there are some treatments that could help that are very different. So it is important to have that diagnosis because the treatment can be very specific. So important to note, we're going to talk medical, but some other potentially helpful interventions. It's really important to note physical therapy because there's so many falls. We'll talk about the movement changes, falls, injuries from falls, balance and stability, mobility, moving around, getting, from the recliner to the toilet, from the bed to the bathroom. Physical therapy is super, super important. I was part of a rehab therapy team at Penn that we really specialized in working with this population, and PT, OT, speech, we were in there from minute one to help. OT, we're really helping maintain that independence, that quality of life. Also looking at changes to vision, to cognition, how to kind of work around ways to approach a task in a different way, or how to change the environment to support the person with Lewy more. There's a lot of changes to speech and communication, and then also swallowing with Lewy body dementia. So speech therapy becomes very important. And I strongly believe all three of those disciplines, if and when possible, should be started at diagnosis. And maybe you're not seeing them. I had some people with Lewy that they were doing great early on, and I gave them some resources, some information, and I'm like, let's check in 3 months, in 6 months, and see how you're doing. Social work can really help connect you to resources, help you cope with changes, get prepared, and really think ahead about things like advanced directives and living situations. And then counseling should never be underestimated. A great psychologist or counselor to help you and your family really adjust to these changes, deal with some of the ambiguous loss that you're maybe having as well, becomes really, really important. All right. So as we're talking about management of Lewy, we're really going to be thinking about the symptoms as they relate to the different symptoms of the condition. So the cognitive impairment, we know that is a major feature, right? Neuropsychiatric features, we're going to get into what those look like. Those different motor symptoms, that stiffness, the falls, the changes to movement. There's a variety of sleep disorders that can come along with Lewy, and then also changes to autonomic function. And the thing that's important to note right here is that interrelationship we've got in that Venn diagram. The symptoms kind of play off of each other a lot of times too. So if someone's having poor sleep, for example, they might have more neuropsychiatric changes. They might have more hallucinations, more delusions. If they're having autonomic issues, then they might have orthostatic hypotension, which leads to more falls and changes to their movement. So they're not really isolated in separate buckets. Unfortunately, they do really connect and intertwine a lot. So let's start with a big beast, the cognitive symptom management. As I kind of talked about a little bit in that diagram with Alzheimer's earlier, we're talking about mostly impaired attention, changes to executive function. So following steps and stages and process of things that we do. Bradyphrenia just means slower thinking. And so everything you've probably noticed gets slower. Their movement gets slower. Their thinking gets slower. Often they have a visuospatial impairment. So they'll have spatial disorientation where they might set a glass too close to the edge of a table, or start to have problems driving early on and kind of with lane negotiation. They also visual misidentification can be very common. And I learned this the hard way when I was in my clinicals at Mayo as an OT. And I had my first patient with Lewy, and every person he saw, he thought he knew them. It was Chuck, or it was Phil, or it was Ted. And then he would get really agitated sometimes when Chuck or Phil or Ted didn't recognize him back. And so I really was like, whoa, I hadn't seen that level of misidentification. And this can lead into some of the neuropsychiatric symptoms sometimes too, where we see like Capgras delusions. Also, with the progression of the disease, we do see more changes to memory. And those cognitive fluctuations, I'm going to go into a little bit more in a second, but that's that roller coaster ride where 1 minute they're on and 1 minute they're off. You'll notice there's some medications here listed that can be used for cognition. I really encourage you to discuss these medications with your doctor. I am not advocating for any one medication or telling you you need to be on one of these or opposed to these. This is a conversation for you with your doctor, but I think it's important to note the medications that are available and appropriate. And you'll notice here too, as I mentioned earlier, occupational therapist, speech therapist can really help with workarounds for addressing task in a different way, maybe modifying the environment to support the individual with doing those tasks. But it's important to know that there are things you can do and there is help available. When we talk about those fluctuations, it's important to note what these look like. These are very much hallmark of Lewy. So you're going to see changes to the level of concentration and attention. People will often have a moment of showtime or clarity when you get to the doctor, and then the care partner, you're like, wait a minute, you've been telling the doctor all these things are going on, and then you get to the doctor and they look great. So that can be part of that fluctuation. Or maybe friends or family come over and they're like, looks good to me. I don't see what you're complaining about. But that can also be, as you know, living with it, there can be these unexplained episodes of confusion where someone seems completely confused and out of it and zoned out. And this can even be accompanied by excessive daytime sleepiness. So, this I think is one of the most challenging aspects of the disease to live with. And also, as you're talking about strategies or different things that you're trying, this can make it hard, right? Because it works 1 minute and then it doesn't work the next, or works for 2 weeks and then it stops working. And so it makes it like a moving target, really. So I wanted to throw in some strategies here to support visuospatial function because so many people are not aware of the visual changes and what that can mean. We also have a great webinar on this, and we have a really good resource about visual function and kind of adaptations around it with Lewy. But really start to think about looking at your environment and the contrast within it. So what do I mean by that? If you've got beige walls and beige carpet and beige furniture, everything just kind of disappears. There's nothing to really tell your eye where something is. So looking at the color of their phone compared to the table they sit it on, right? Maybe the chair that they're having trouble finding, putting some type of a bright throw or a blanket or like a colored pillow on it so they can see that contrast. Visual targets can be great too, using coasters or placemats for where to sit that glass so they can see it better. A lot of times people go to using glasses with dishes or dishes that have color. Non-breakable melamine things can be nice too if things are getting knocked over, or dropped, or broken. And there's so many great options out there now that can really help with that visual acuity. Using some colored tape. I had like rolls of colored duct tape on me in my OT job. And if somebody was having trouble finding their phone or the button on their remote or whatever, out came the colored tape just to give that contrast. Check the lighting in your home too. If it's really dim, if it's really dull. I know when my friend comes over, I'm kind of a dim light kind of person. I have some visual or kind of light sensitivities. When my friend with Parkinson's disease dementia comes over, we take the lights up. Because if it's really dark or kind of lamp lit, I have a lot of like art glass lamps and stuff. It really impacts his navigation and his ability to move in the space. And then lastly, minimize clutter. It's really hard to understand how to navigate in your environment if there's a lot of clutter around. And that could be navigating to find your cup on the table, or it could be navigating down a hallway in your home. So really think about that. All right, let's talk about motor symptoms now. So there's a lot of different common symptoms that we see here on the left-hand side. So tremor can be common, but a lot of people, I got to tell you, don't have tremor, Or if they have tremor, it was for a little while and then it can go away. It typically starts on one side. It's more common at rest with this condition. So, meaning when the hand is just resting or sitting. But some people do have an action tremor. So, when they go to reach for something or do something with the hands. There's that Brady word again. Now we've got bradykinesia. So that means slow movement. So you'll notice that they start to move. It takes shorter steps, kind of smaller steps, kind of everything looks a little slowed down. Rigidity is that stiffness that we see a lot of times at the elbow or at the knees. Myoclonus can be kind of a jerk or almost a tick looking type of movement. Often the shuffling gait is very common. So reduced foot clearance, the feet are just kind of on the floor and they'll shuffle. We had a jar in our clinic that one side said it's the shoes and the other side said it's the carpet. And if they ever said that they had tripped or fallen or whatever happened because it was the shoes or it was the carpet, they had to put $1 in the jar because they don't lift their feet up. And so that's one way that we talked about it there. That stooped posture that we see, typically where the head's kind of forward, the body's forward, and that can go really forward sometimes with like camptocormia is a condition where people are really bent forward at the waist, or Pisa syndrome. The face can look very masked often and frozen. And this can be difficult for grandchildren, for communication, because we don't realize how much we read someone's facial expression, right? Until there isn't any. And then sometimes they'll think, oh, they look like they're mad at me. Or sometimes, care partners will say, I don't see that love in their face anymore. And it's just the rigidity and the stiffness in the facial muscles. It's not really how they feel. And then drooling or sialorrhea is a common symptom. So that excessive kind of drooling. So the medications here are listed. Carbidopa levodopa is pretty common. Sinemet is one of the names that you'll hear of that. There's some dopamine agonists. It's important to note when we talk about medications later, the problem is sometimes if the dose of dopamine is too high, it can make the hallucinations more, the psychosis more. So it can be a real balancing act for managing the motor symptoms without triggering or tripping up the neuropsychiatric symptoms. And you'll notice down there too, I commented to physical therapy, occupational therapy, speech therapy, really, really important for these motor symptoms, for home safety, for looking at ways to help them move, maybe getting a gait device or cueing. Sometimes just verbal cues can be really helpful from the care partner. So then looking at sleep, we saw this was one of those symptom buckets earlier, right? So some common sleep disorders, sometimes even 20 years prior to the condition, we'll see REM sleep behavior disorder. And sometimes people will describe this as night terrors, where it's actually they're acting out their dreams. And they can sometimes punch or hit people or even fall out of bed and get injured. And this is one of the common symptoms used for diagnosis. Excessive daytime sleepiness is common. Trouble falling asleep is insomnia. Oh, we do see more obstructive sleep apnea and central sleep apnea. And then restless leg syndrome can be a problem. And even people feeling like their limbs just periodically move when they're sleeping and it kind of wakes them up. So you'll notice, we've got some medications here. Melatonin, a lot of times, is where doctors will start. Even though it's over the counter, I encourage you to make sure that you're talking with your healthcare provider about that because you want to monitor for side effects. You'll notice there's some other drugs mentioned there as well. And we really want to look at how to improve safety in the sleep environment if this REM sleep behavior disorder is going on. And often a nasal CPAP may be ordered. So sometimes you need to see a sleep doctor with this as a specialist. When we get into autonomic symptoms, we recently, little side plug, we have a great webinar tomorrow. If you want to learn more about these sleep symptoms and kind of what to do about them, how to cope with them, we do have a webinar tomorrow at 2:00. And then this autonomic one, we had most recently with Dr. Shannon Chu, and that's available on our YouTube channel where she goes through all the autonomic symptoms. So like I said earlier, orthostatic hypotension is common where the blood pressure drops 20 millimeters of mercury or more when you change position. So that's usually going from sitting down to standing. Sometimes people will feel lightheaded or even fall. And it could be going from lying down to sitting up. Impotence is very common, urinary incontinence, and then even constipation. And so you'll notice some of the medications listed there on the side. There's things that you can talk to your doctor about to manage these symptoms. And then physical therapy and occupational therapy here become really important because, especially with orthostatic hypotension, you're talking about managing that when you're moving and trying to focus on safety then. Also with OT, a lot of times we're talking about things around urinary incontinence or around constipation and how to manage those things. So you want to make sure that you're getting the full meal deal as much as possible. This is the elephant in the room, though. The neuropsychiatric symptoms by far are the hardest to manage and control and live with, even. So, common symptoms here: visual hallucinations. So, seeing well-formed people or animals that aren't actually there. An illusion is kind of a trick of the eyes, where maybe there's a coat hanging on a coat hanger and on a rack, and it looks like a person. So that's an illusion where the eyes don't really pick up that image clearly. Delusions are those fixed false beliefs, often paranoid in nature. So, ones that we hear a lot are about infidelity. And that's hard. If you're a care partner and you're caring for someone, and then now they think you're cheating on them, and what we hear from care partners is like, with what time? Like, when would I be doing this? But just please note that's not your loved one, and it's not any type of a symptom of your relationship or anything that way. It's part of the neural changes in the brain that they can get very paranoid, and a lot of times then those delusions are geared toward you. Capgras syndrome is called the imposter syndrome, and that's where your loved one might think that you're an imposter. I had a dear patient one time, and I'd been working with her for a couple of years, and she had Capgras delusion about her husband would think he was an imposter. It's not him. She locked him out of the car one day, let me in the car, but wouldn't let her husband of 40 plus years in the car. And so that can be so upsetting and frustrating for families and care partners. And then, of course, depression, anxiety, even apathy. So that loss of interest in things that maybe they used to like to do. Very, very common changes to mood. And agitation or aggression can also happen. That could be verbal, that could be physical. They might yell at you or become more angry than they have in the past, or maybe strike out physically. You'll notice there are some medications here on the side, and I want you to really pay attention in red. Haldol. Haloperidol is one of those drugs that I was talking about with Alzheimer's or a lot of dementias, that if you go into the ER, if your loved one goes into an emergency setting because they are having psychosis or they're agitated or aggressive, the number one drug they'll reach for a lot of times is Haldol. Unfortunately, it can cause really dangerous problems for people with Lewy or with Parkinson's because it blocks dopamine. So it can be fatal. So we do have a great medical alert card that you can download off our website, or you can reach out and we'll send one to you that advises and kind of warns of this if you end up in that setting. And then education and counseling, also really, really important in this realm to help you understand the symptoms, I think, is a lot of it, and cope with them, and work together, as a unit to try to really cope with these things long term. So, some tips for supporting altered perceptions. So, those delusions, those hallucinations here. First, you want to rule out any contributing physical ailments. Why is it that a urinary tract infection causes our head to go all goofy? But it does. It's like if someone has a UTI or some kind of an infection, then that will really a lot of times cause more of those altered perceptions, of those cognitive issues, of stuff. So you want to watch out for that. You might want to review medications. If they're having a lot of hallucinations and delusions, it might be time to talk to your doctor, maybe about some of those movement medications that might be triggering that, some of those dopamine drugs. You want to look at any environmental or social factors. I had an interesting question recently from someone in a webinar that said, well, our son's daughter, our wife, really wants us to have more relationship with the in-laws, but for whatever reason, the husband, the father that had Louis, did not. He would always get kind of triggered or anxious, or it was always a problem. Who knows why? I didn't really ask a lot of questions. Is there a history? Do those people just maybe rub him wrong? Do they look like someone that maybe he didn't like? But thinking about those social factors, is it that important to maintain that relationship if it's causing symptoms and issues? Are there things in the environment you could adjust, like that coat hanger and that coat hanging that looks like a person? Um, Always best to try these non-pharmacological or non-drug approaches to management first rather than just seeking out a medication, because the medications can have a lot of side effects. And then a lot of times, an antidepressant can be really helpful before they try like an antipsychotic. So definitely something to discuss with your doctor. And when they do use any kind of an antipsychotic medication, you want to monitor closely for possible side effects. So if they say, okay, we're going to start trying Nuplazid, or we're going to start to try Seroquel, or whatever this drug is, you want to really chart changes to things that you see and really look at possible reactions. So some of those non-drug management strategies that I think are really helpful, and keep in mind, I understand they look a lot better on a slide than they do trying in person, because it can be really, really difficult to stay calm and avoid arguing with someone. But you really don't want to try to argue with a hallucination or with a delusion. Try to stay calm, reassure the person that they're okay. If they're scared, get them to an environment that feels more safe. Offer some distractions, maybe favorite music or an activity that they enjoy. Um, get them engaged in a simple task that they are interested in. Maybe there's something that they like to kind of, tinker with or do. That might be something to kind of move them toward that. Having a daily schedule can really help a lot, keeping things very consistent and then being flexible, of course, around those fluctuations, but trying to keep some consistency. Regular exercise and sleep are very, very important. And I know, like we talked about the sleep disturbances, that can be hard to get. And then exercise, you might need to enlist a physical therapist that can help with that, or maybe a personal trainer that's really a medical fitness person and knows how to work with people with Lewy. But getting those wellness factors in check is important too. We just did a great webinar on exercise recently with a physical therapist, and we'll be putting up a course on our Lewy Learning Center with different videos that you could follow along with and do the exercises, if that's helpful. And then moderate environmental stimuli. So if there's a lot of noise going on, or a crowd, or a lot of people, or maybe you've got the television and the radio on and they're doing road construction outside, that might be too much. A lot of times taking down the stimulation can be helpful. For those visual hallucinations, I wanted to throw in some coping strategies here. When they're frightening, reassure them they're safe. Like I said, think about getting to a different room or going to, a different environment. Try increasing the lighting and maybe some visual and auditory stimulation by adding in some of those activities. Try to avoid spending long periods of time with uh, just a little lamp on and we're sleeping and kind of snoozing in the recliner. Having that breakup of, activity and rest can really help. The longer someone really just goes into that lethargy stage, it seems like that can really trip up the hallucinations a lot too. Um, Work with your doc to prevent sleep deprivation. Try to maintain a proper day-night schedule. That can get off sometimes for people. OTs can help a lot with that as well. So if you find that they're really having trouble with sleep and that seems to be triggering more psychiatric issues, definitely try to work on that with your doctor. Important to note that poor vision can also lead to visual hallucinations. So make sure that prescription lenses are being kept up to date. Sometimes people with Lewy need to see a neuro-ophthalmologist or an ophthalmologist instead of an optometrist, but someone who really understands kind of the changes that are going on neurologically to their vision. And they might need a different type of lens for something. Sometimes a prism lens is recommended for near work, but then not when walking around. So something to keep in mind. Another thing I want to bring to your attention as far as management that you want to really be mindful of is sensitivity to different medications. So, our folks with Lewy become really, really sensitive a lot of times to different drugs that you wouldn't think about. So, I kind of talked about haloperidol earlier. Thorzine's listed here. So, these block dopamine, right, and can be very dangerous. And these are kind of what we call traditional antipsychotics. It's what they're going to just usually give on a whim. And like I mentioned, some of those medications can cause a worsening and a condition called neuroleptic malignant syndrome. So what you're looking for there is, are they having severe fever? Are their muscles getting really, really rigid? That can lead to kidney failure. But, I know this can be really difficult to advocate in care settings for, but trying to have that medical alert card, talking with the care team, making sure they know not to give Haldol, very, very important. And important to note that benzodiazepines can also can increase anxiety or worsen cognition. So some of the things that you typically give to help can make things worse. Um, and then important to note over-the-counter medications. So some allergy medications, cold medications, things like that can interfere with the cholinesterase or with the acetylcholine system in the brain. So they can cause complications. So basically, what I always told my peeps with Lewy was, if you're going to start or take any type of medication, you want to talk to your doctor about it. And you don't ever want to stop or change a medication without talking to your doctor about it. So you don't want to just cold turkey a drug and see what happens. You want to definitely make sure that you're having a conversation. Some of these drugs too need to be titrated down. Like you have to reduce the dose in kind of increments to prevent other things from happening. So very sensitive to meds here. Another thing I want you to know is how dangerous hospitalization is not fun for anyone. I just went through a hospitalization with my daughter a couple of years ago. She was 12 and having a planned surgery, and it was one of the biggest nightmares of my life that I've ever dealt with. And we were at a very good hospital, by the way. So this is never fun, but you want to think about how you can be prepared because of the risk of falls with the condition, with psychosis, with things that can happen. I encourage you to have like a little bag prepped at home, a little kit ready to go, where you have copies of their medical history, you have a current medication list in there. You can download copies of the medical alert wallet card from us, or you can reach out and we'll send you a copy. I'm going to talk a little bit more about the Diamond Lewy Toolkit, which is a guide for doctors. It's like a cheat sheet on the medications, kind of which ones to use, which ones not to use. You can always ask the physicians to try to contact your doctor that treats them for Lewy. See if you can get them to communicate too about the dangers of this. And then discuss the risk for severe reactions with some of these medications with the hospital staff and nurses. And I know that's such a weird place to be, to feel like you have to kind of advocate to medical professionals for what they should or shouldn't do. But trust me, I had to do it a few times. I had to not let a nurse put a pill in my daughter's mouth that she had picked up with her false fingernails from the tray of a computer keyboard. So sometimes things happen. We can get great care in hospitals, and we know there's amazing medical professionals out there. Sometimes we don't get the greatest care and we have to advocate. And so that can be awkward. And we're coming out with some resources this fall to help with that, because we've heard this from the community that, they ask me if we can't give Haldol, then what do you want us to give him? And we're like, I don't know. I'm not a doctor. So, we want to help you with that. We want to support you with that. But think about, if you haven't already done this, how could you prepare? There's also a great kit from the Parkinson's Foundation on safer hospitalization. I think I might even have it over here somewhere. And you can download that and use copies of that as well. Because remember, this is related to Parkinson's disease, the same sensitivities to medication, some of that. So there's some of those documents that would actually probably be really relevant as well. All right. So that non-medical management, I'll try to get through these here quickly so we can take some questions. We kind of talked about all of the therapies here on the side. You want to think about different integrative practices. There's great research on music and creative arts. We had an excellent webinar this year with a music therapist, and talking about how you can use music, different art mediums, be it painting, drawing, whatever it might be. I had one lady that had a lot of tremor, and she would dip a straw in paint and blow it on a canvas and make art. She said she felt like a little mini Jackson Pollock. So get creative. There's some evidence for bright light therapy, exposure to nature, bird watching, animals, hikes, Aromatherapy, if sense of smell has not been impacted. Pets, so sometimes having a pet to come and visit, or a pet that lives with you, if that's not too much to maintain. Really think about your environment. This is one I think that people take for granted. Thinking about those day and nighttime routines and how to have consistency so that those stay really separated. Looking at home modifications. We have a great course on our Lewy Learning Center, where I had an OT go through different changes you can make to your bedroom, your bathroom, your kitchen to make it more accessible. Think about home safety. So having PT and OT come in and look at some falls prevention. Is it safe for them to keep driving? We never want to talk about it, but it's definitely something to consider. And also with the delusions and paranoia and hallucinations, thinking about firearms and where those need to go, or if safety locks need to be on them, or what we need to do to be safe there. Avoiding crowds, distractions, thinking about if you're booking a restaurant, maybe you're not booking the one that blasts the music and is really large. Maybe you're going to that tiny intimate cafe that's kind of quiet. There can be some assistive technology to help with, memory compensation or safety. So some things to check into there. And then really looking at lifestyle, talking about the communication. This is a big part for speech language pathologists, how to communicate with one another with a lot of the changes going on. Movement and exercise, stimulating the mind. You guys, they're still there. Don't think that, I hate nothing breaks my heart more than when I hear, well, they're not really there anyway, because that's really not true. I had a guy come in one time with Lewy, very impaired and very much in the later stages, and no one felt like they could reach him. And he loved old cars. I sat and went through websites with that man because that's all I had at the time. Pictures of these Corvettes that he loved. He could tell me what type he had. It was amazing to see him. His wife just sat and cried because she hadn't been able to connect that much with him. But it was really finding that interest that was in there and how to pull him out with that. And that can look at, new projects or hobbies, or looking at past interest. There's a program called Tailored Activities Program. That's what that TAP stands for, that you can work on, and really make sure you're tailoring the activity to the individual. Making sure we're getting some social engagement. We definitely learned with COVID how vital that is. And even looking at healthy eating, because constipation and a lot of those issues can really be impacted by how we're eating. So I want to leave you with this. I want you to think of, we're thinking about how to, really manage some of these non-pharmacological things and how to engage. You want to focus on the strengths rather than what's been lost or changed. Just because someone can't do something independently, right, doesn't mean that they can't do it at all and somebody needs to do them. Maybe they need a little accommodation to the task, change it a little bit, or modify the environment. Maybe they need a little assistance, like getting the shirt organized in their lap to put it on. But that doesn't mean you have to just put it on them. And I think this is something a lot of times what I saw for many years with my care partners is how they wanted to be a good care partner and they wanted to provide the right support. So a lot of times they would just start doing everything. And I know it can be hard sometimes to go, well, what part should I do and what shouldn't I do? That's where a good occupational therapist, physical therapist, speech therapist will help you kind of navigate that realm and work together. All right. So with that, some takeaway points for here. Important to have a diagnosis. That really supports best management. So I wanted to make sure I didn't leave that out. Establish a multidisciplinary care team, and you want to build your village people, your PT, your OT, your speech therapist, your counselor, your social worker, maybe some specialist clinicians in there, and with them create a personalized action plan that includes both medical and non-drug approaches, so you're working from both ends. And then one that might not be on your handout, I just added this one in: track and monitor changes to symptoms. So you want to keep an eye, especially if a new medication's added in, you want to kind of keep an eye on what's going on. There's a lot of great symptom trackers out there. You can just use a notebook, just kind of noting what you see. Seek out support and resources. You're doing that by being here, right? And staying active with your family, with your church communities, with support groups, however that works for you. And then so important to continue to live with purpose and focus on all aspects of your well-being as much as possible. And I know that can be really hard to balance and juggle within all of these things, but trying to keep your eye on the big picture too of, staying connected with family and friends and doing things that you love. All right, I'm going to take questions really quick. I want to go through some resources. And the most important thing I want to leave you with as care partners is give yourself grace. I treated mostly things that people didn't like to treat because people didn't get better from them. Huntington's disease, ALS, Parkinson's, all of these things. And what I have to tell you is it's difficult. Lewy is very, very challenging to live with, to cope with, to manage. You're doing a great job. That's the best thing I can say to you is whatever you're doing a great job, and remind yourself of that. You're not going to be perfect. No one expects you to be. This is challenging, and give yourself that grace. All right. And we can help. Reach out to us. We work to drive awareness in events like this, educate people, really drive research, but also support. And we'll talk more about how we can do that for you. We have a lot of educational resources that you can reach out, and we'll send them to you, or you can download them off our website. I mentioned the Lewy Learning Center. You can Google Lewy Learning Center. It's this Lewy Learning Center at thinkificthebottom.com. A lot of education on there. Our research centers of excellence, if you're looking for a highly specialized medical center that really understands Lewy, this is the place to find them. They're mostly academic medical centers, so there are about, I think, 22 of them at this point, but they really have a lot of research and support and great clinical care as well. If you want to see any of our past webinars recorded, you can go to our LBDA TV site, which is our YouTube channel. So go to YouTube and put in LBDA TV, and that will take you to the recordings of all of our webinars. If you're interested in learning more about research, we have our Lewy Trial Tracker, where you can go on and sign up. And you're not signing up to be part of a research study. You're signing up to learn about what's available, what might be in the pipe line for you to maybe sign up for if you were interested. We have a Mediflix channel. That's also another place you can find some of our webinars, and you can also view the film Spark if you want, or share that with family maybe that are needing a little more education. If you have any PTs or OTs or speech language pathologists in your world that need more education, this is a great course that we do for them on Continued. I think I didn't put in the slide about Diamond Lewy Management Toolkit. I apologize. This is the biggest thing, though. If you remember nothing and forget everything else that I said today, our Lewy line is staffed by 2 social workers. It's not an all-night 24-hour hotline. They really keep business hours, but you can call 1-800-539 9767. They can connect you to support group leaders, to clinicians in your area, to resources you might be looking for, to resources on our website. Hey, that girl said something about this thing on your Lewy Learning Center. I don't know how to find it. They can help you get there. You can also email them at support@lbda.org. And with that, I thank you very much for your time and attention, and we'll try to get some questions in here.
Thank you, Julia.
Thank you.
We have quite a few questions here. Let's see. The presentation slides, I'll answer this question. She did give me a copy. I will send those out via email to everyone. This is also recorded. How does LBD differ from Alzheimer's regarding hallucinations? Do hallucinations include audio hallucinations?
They can. That's a really good question. So the hallucinations can involve any of the senses, right? And what's fascinating is sometimes people that have visual hallucinations, the auditory hallucination will pair up with it. So like they'll see a person and then the person's talking to them. So that validates it even more, right? Even if you're experiencing it, that it's real. Sometimes people will smell really horrible smells. They can have some smell sensations or even touch. One of the really common ones too is what's called a sense of presence. So people will perceive like there's a person just out of their peripheral vision or just out of their corner of their eye, and then when they turn to look, they're gone. So definitely a variety of hallucinations. Visual are the most common, but absolutely they can involve any of the senses.
Thank you. Can you explain the difference between long-term and short-term memory?
Absolutely. So when we're thinking about long-term memory, guys, we're talking about things that have happened in your life, right? So who your parents are, your maybe where you grew up, maybe where you went to church, your grandparents, things like that. Those are things that we've kind of stored along the way, right? So they're long term. They've happened to us over years and been kind of put in our memory banks. Now compare that to you go, oh, I'm going to go to the kitchen and get a glass of water. And you get halfway there and you go, wait, why was I coming to the kitchen? That we a lot of times call working memory or short-term memory. So it's in the moment, a lot of times kind of recognizing or remembering what you need to do. Procedural memory or not procedural, sorry, perspective memory can sometimes be part of that too, of what you need to do when you need to do it. And we also see changes to that. But definitely big difference with Alzheimer's. That's typically what we see are those changes to that long-term memory, right? And that's what I have people all the time come up and say, well, he remembers all the grandkids' names. He just sees raccoons running up the wall. Well, yeah, he's not going to not remember the grandkids' names more than likely. Now, he might not remember, what he went to do at that moment or if he took his pills or not. But yeah, very, very different. Good point.
Okay. And then life expectancy is based on the date of diagnosis, or is it the date of the onset of the symptoms?
So let me look back at that slide because I know I was very clear with my wording for a reason on that, and I want to not mess it up here. From the time diagnostic symptoms appear. So what that means is the symptoms that they use to diagnose. So that would be REM sleep behavior disorder, right? The Parkinsonism, the changes also to psychiatric disturbances, so like the hallucinations. From the time those symptoms that you would use to diagnose someone start to appear, the average is 4 to 7 years. But like I said, close, narrow window, right? Where it's a much broader picture.
Thank you.
Yeah.
Is dizziness and balance a part of Lewy symptoms?
Balance impairments are definitely part and parcel of Lewy, just like Parkinson's, right? And the dizziness that can happen often is part of that orthostatic hypotension. So if someone's having dizziness and balance issues kind of upon standing or changing positions, you definitely want to let your doctor know that. That could be some of those autonomic symptoms that we talked about. So yeah, very common.
When can palliative care be provided and covered by Medicare to help a patient with dementia, even when the diagnosis is not terminal and hospice is not required?
My understanding is this. Now, keep in mind, I am not a Medicare access expert. So, Melissa, if you know when it can be, please let me know. My understanding is it's all about how it's kind of coded and billed and approached. Palliative care supports quality of life and should be accessible from diagnosis. That someone can have palliative care services. Now, that changes over time, right? As far as what the services are as the diagnosis is progressing. There's no reason you shouldn't be able to access palliative care. Is that correct, Melissa?
Yeah, I think there's some insurances that are particular with that, and you may have to pay out of pocket, but that's insurance based. So, but the minute you're diagnosed, you're eligible for palliative care.
Excellent. Yay, I knew an answer.
Neuro psychiatric slide. Is it increased paranoia a part of the symptoms?
Yes. So paranoia is usually at the root of a lot of the hallucinations, a lot of the delusions. It kind of, they tend to be paranoid in nature.
Perfect. When looking to bring in home help, how do I screen for professionals with knowledge and experience with Lewy body?
So what I would do actually is the more common way to think of it is people have heard of Alzheimer's and they've heard of Parkinson's, right? If people have Parkinson's experience, I think you're probably going to do better than if they have Alzheimer's experience. Because most of the time, by the time you have someone who's doing home health with someone with Parkinson's, they're probably in the later stages, more likely to have cognitive impairment and movement changes and be more like someone with Lewy. So I would look, and a lot of times you can find, you guys, there's a great resource to the Global Care Network from the Parkinson's Foundation has a list of I don't know if it includes home health agencies now that I say it, but I know it has some long-term care. There's some different partners in their network that they train and vet and make sure they know and understand working with people with Parkinson's. So that might be a place to look.
Perfect, thank you. What happens to the patient when he goes into a deep sleep that appears to be a coma for 1 to 3 hours? Caregiver cannot awaken him. When he wakes up and talks as if nothing has happened.
Yeah, that I would definitely, talk to your doctor about. That can be one of the with sleep. Some of their sleep is really, really deep, and they can sleep a lot too. And I believe, there's some of the way that the sleep symptoms present too that can be indicative of kind of moving into later stages and kind of end of life type of issues with sleep. So I would say talk with your doctor about that. I don't think it's probably anything to be really concerned about. I think it's just the nature of the sleep symptoms.
Yeah. What are some diagnostic tests for LBD?
So let me pull this up because I don't want to misspeak. I'm gonna make sure I get these right. So there's so many different types of PET scans too. I don't want to say the wrong one. So basically, you guys, it's still considered a diagnostic or clinical diagnosis, right? So they're going to look at factors related to symptom presentation, how you move, things like that. But there are some tests that can be done that can help. And so one of those is a DAT scan. And a DAT scan looks at dopamine uptake in the brain, and it can be used to diagnose Parkinson's too. So it's not really going to tell you if someone has Parkinson's or Lewy, it's going to tell you if they have Parkinsonism. Now, keep in mind with that, remember how I said not all people with Lewy get Parkinsonism? Well, guess what? If there's not much Parkinsonism, then it won't show up on a DAT scan. So you can get false negatives sometimes. So what they're looking at here is the core features. In fact, I'm going to blow this up a little bit and I'm going to share screen because I think this is important for you to note that we have this as a resource, if that's okay,
Mhm.
and what this looks like. So let me see. Can she find the right window? Hold on. Oh, here we go. I got it. I got
While
it
she's
here.
looking for that, I just want to remind everyone this was recorded and we are going to provide the slides through an email afterwards. So,
Trying to blow this up here a little bit. There we go. So this is our diagnostic symptom checklist. And on one side, it has a place where you can check off the symptoms, right? This is what I want to talk about here per your question, is looking at this criteria. So you'll notice there's core clinical features. And so they're looking at the fluctuating cognition, recurrent visual hallucinations, REM sleep behavior disorder, and one or more spontaneous cardinal feature of Parkinsonism. So, slowness of movement, decrease in amplitude, rest tremor, or rigidity. These biomarkers here are ones that can be indicative. So, the DAT scan that I just mentioned, abnormal MIBG, myocardial scintigraphy, and then a sleep study, right? And so, there's different ways that they can look at those biomarkers as well. There's also these supportive clinical features, which I'm not going to read off here, but you notice basically these are just kind of the symptoms we talked about today: anxiety, depression, falls, orthostatic hypotension. There's also some supportive biomarkers that can be used. So a CT or MRI scan, SPECT or PET imaging, and then also they can look at some aspects of an EEG. So those are kind of the different things that they can look at and take an example of. There are more, just more biomarkers coming out. That diagnostic criteria was from 2017. So now they're able to do a skin test, right? And test for alpha synuclein. Once again, it doesn't necessarily tell if you've got Parkinson's or Lewy. It tells you if you have the presence of alpha synuclein. So you have something in that family.
thank you. How do you know when medication is needed? My goal is to limit pharmaceuticals as much as possible.
I think that you really want to look at your quality of life with that. And I completely hear that, by the way. I'm not someone that likes to take a lot of drugs or medication either, especially when you consider how they can cause other problems. But I'll do a devil's advocate for you. Let's say that you're having changes to your movement so much that you're having trouble getting dressed. You're having trouble doing your buttons. You're having difficulty walking and moving. And that if it's impacting your quality of life to the point that you can't do things for yourself, you're getting frustrated, you're needing help, I think it's time to at least talk about the medications and see what. Now you always want to ask, what will this do for me? Is that medication actually going to help me with whatever the problem is that I'm having? So I think that's what you want to look at, is it impacting my quality of life? Like, for example, the hallucinations, the rule of thumb is sometimes hallucinations don't bother the person. I had a guy that he saw babies. Babies are cute, they're not scary. And so a lot of times the rule of thumb is if it's not scary or distressing or alarming or impacting your quality of life, why treat it? Why risk that? So good question.
Thank you. I know you said you wouldn't be talking about getting a diagnosis, but can you steer us in with some tips and resources for the diagnosis? I think you just did that with some of the tests too.
Absolutely. I would definitely say take a look, get our diagnostic symptom checklist, download that, do that. There's also what's called the Lewy body composite risk score. Wondering if I have a link. I could send it out to Melissa and she could share it with you guys. That's another one they can check. And if you have, I think, three or more or something, then it's like a 90% likelihood. So I think there's some things like that that you can do to kind of advocate and empower yourself to talk about that diagnosis. And then also the types of clinicians you want to look for. Steer away from general clinicians if you can, or general practitioners. Sometimes psychiatrists do a really good job. If you're having a lot of neuropsychiatric stuff, we've done a lot of education with psychiatrists. They sometimes spot it earlier. Also, movement disorder specialists, neurologists, which is a specialized form of neurology, and cognitive neurology. So a lot of times you want to go at minimum a neurologist. If you can get maybe a little bit higher level of specialty with some of those things, that can help too.
Thank you. Parkinson's and dementia have different etiology. Why does Parkinson's lead to dementia?
Um, So it's really the changes that are happening in the brain. So that with Parkinson's, what we know is that, or this is the hypothesis. There's definitely arguments about whether the alpha synuclein and that misfolded protein is the start or the result, kind of another chicken or egg moment, right? So what happens that we do know anyway is as those proteins clump and misfold, it almost spreads through the brain to different parts of the brain, to different regions of the brain, and then you get cell death that starts to happen. So that result of that cell death, that lack of neurotransmitters, that's what's causing the dementia within it. So that's why some people, there's a certain mutation in Parkinson's. I believe it's the LRRK2, but don't quote me on that. I'm not a geneticist. There's one of the genetic mutations where people really don't have many cognitive changes. For whatever reason, the parts of the brain it affects, the way it spreads, it just doesn't really impact that as much. So you're really talking about that pathological, the spread of the disease through the brain.
Thank you. Which is most appropriate for end of life with Lewy body care, assisted living, memory care, or skilled nursing? If skilled nursing is called for, what is the appropriate time for transition?
Oh gosh, that is such a complex question.
It
And I
is,
know
and it's a
Melissa.
loaded question.
Yeah.
I
Yes,
think the piece of advice we give is when safety is an issue, that's when you can move them. But if you are able financially to keep them at home and have all the support, and that's what they want, that's always a way to go to. So you don't necessarily have to move into a community. It depends on your safety and their safety, and that's the biggest rule of thumb, I think, with that.
absolutely. I agree completely.
Yeah.
And
Okay.
I will say one thing, I'll throw this in there. If you think, like, let's say you're in a home that you don't think you will be able to maintain staying in, mobility wise or safety or whatever it is, I would encourage you to start looking, thinking, planning sooner rather than later. At the point that the cognitive changes, the neuropsychiatric changes really set in, it makes it harder to move and transition. So you're better to just go ahead and get it done early. Like my friend with Parkinson's disease, dementia, I was on them, and was like, you got to get him out of here because there was no way he was going to be able to stay in that home.
Yeah.
And they almost did it too late. It really kicked up his psychiatric stuff. He didn't have a lot of psychiatric stuff. Then when they moved, he did. He was convinced that people were pumping psychiatric drugs in the ventilation system that were working on the road outside. So you want to do it sooner rather than later as much as possible.
Perfect. Thank you. How do you advise with dealing with physical violence or verbal abuse from your loved one with Lewy? Also, knowing when to place and how to deal with refusal of medication, psychiatric help, or medical intervention. So
Oh
we
my
answered half
goodness.
of that.
Absolutely. I think you always want to think safety first, just like Melissa said. If you're at risk and in harm's way, then definitely it's time to talk to your doctor about this and remove yourself from the situation. call and get help as needed. But I do think that there's not really a clear cut answer on that. I think that it's something to really have a conversation with your doctor about, and to prioritize safety for you and your loved one, and what's best. Anything you want to add, Melissa?
I think that kind of sums it up. One person would like you to explain sundowning.
Yeah, so sundowning is what we typically see when there's a change to light. So it's going from daylight to dusk outside. There's a reduction in light, and people can start to have more psychiatric symptoms. So a lot of times, delusions, hallucinations, things like that can become more with that. It definitely, I think you see it some in Lewy, in the sense of, I think, more the delusions and some of the illusions, like we talked about, start to become more if light isn't good. So absolutely, it's important. That's one of those environmental things to really consider.
Thank you. What about lumbar puncture or skin biopsies to look at the alpha-synucleins?
Yeah, so those are the two tests. So you can do a lumbar puncture to test for alpha-synuclein, skin biopsy. The problem is, a lot of times these aren't necessarily widely covered yet, as far as how you can get those tests. Like I said, it doesn't tell you if you have Parkinson's versus Lewy, for example. It doesn't necessarily mean you have dementia just because you have alpha-synuclein. So yeah, those tests right now are a little limited, but I think we're going to see that coming on more and more.
And how about the SYN1 biopsy?
Yeah, so the SYN1 biopsy is that skin biomarker, I believe. And same thing, it's not, it's funny because it's like the people that make SYN1 say it's widely available, but then I think it's pretty limited in how you can get access to it, depending on your provider. But I mean, it definitely, it does test for it. It's pretty accurate, I would say, too. But like I said, it doesn't tell you which ism you got.
And so there, underneath question to that, there can be false negatives with that test. Can there also be false positives?
That's a good question. I don't really know. The scientist in me assumes that there can always be a false negative or a false positive, but I wouldn't want to speak to that.
Okay. Thank you so much. My husband was diagnosed with PD, and so many things do not seem to match. This video has been eye-opening to me and really has directed me to resources that are specific to my husband. He was just recently diagnosed with LBD after a psych cognitive testing baseline done last month. Will motor disorder specialist with PD be the best care for him um, going forward with the Center of Excellence LBD be better?
That's a really good question. Okay, so I'm going to play a little bit of devil's advocate here, in that if he has PDD, which it sounds like, so he had Parkinson's and now he's going to dementia, typically a movement disorder specialist can manage that well, because that's within their scope and within their spectrum. However, I should say that some, I feel like, are a little bit more versed in dealing with the non-motor symptoms and kind of as it goes into that dementia presentation more than others. So I think kind of, just um, maybe talk with your doctor, even if you can, about how comfortable they are with managing. Another question is, if he starts to have a lot of psychiatric features coming in, do they typically have like a psychiatrist in their system that they refer to? What I would want to know, I guess for me, if I have a movement disorder specialist, I want to know what other resources and services are you going to be able to connect me with as this starts to really evolve. Like, is there a social worker in the practice? Are there physical, occupational speech language therapists that can really help with this? So I'd kind of want to know that complete package a little bit too. But you can see a special center of excellence specialty center, but a lot of times those are movement disorder specialists too. So I don't want you to think that you're getting something above and beyond, because a lot of times it's a similar specialty.
Thank you. What are ways you can support an LBD caregiver from a distance? What are common signs caregivers are in trouble?
Oh gosh, yeah. I've been dealing with this with my own family a little bit, how you get the like fine, 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 fine cubed, fine, fine, everything's fine, and it's really not fine. I think that as much as you can, offering an open ear of listening. So, not trying to, do you need help with this? Or, trying to triage and everything. A lot of times people I think especially care partners I dealt with, it's like they wanted to seem like they had it all together and like they were doing okay. So I think if you can just, kind of be like, hey, how are things going? What's your day been like? Just kind of general stuff. As they trust, I think they'll kind of start to sometimes open up a little bit more. I think maybe checking in on like, hey, who do you have that you talk to about this? Like who's your support, and kind of seeing what support they're getting from others. But I think just really being an open ear to listen, because what I found was a lot of my care partners, I felt like viewed it like a failure if they needed support and like the family was reaching out because they needed support. But a lot of times they were, if they just wanted to talk about it and kind of how things were going on, they liked that family was calling or friends were calling and checking on that. There is an amazing study, you guys, too, that you could tell your friends about called the Persevere study. And I can get information on this to Melissa. It's going out of Rush University and it's a peer mentor program for care partners. And so you have a former Lewy care partner that's more experienced mentoring someone newer in their journey. And it's fantastic. They've already done a pilot and they got great data, and then they got a huge grant to continue it on. Jory Fleischer, who runs that program, is an amazing physician. And so that might be something just to share, like, hey, I saw this really cool program. And that can also open the door of like, how are you doing? Do you have support for you? I think a lot of times just asking, because they're so worried about supporting their person, who's supporting you? Like, who's there for you? Anything you want to add to that, Melissa? Because I know you
Yeah,
do
the
a
other
lot of
thing I
this.
tell people, being a caregiver myself, is just having people say, what can I do to help you? If they're saying, oh, I have to go to the grocery store, put the order in, let me get into your app, give me your name and password. I'll order Instacart. It will come right to your door. There's lots of things you can do from a distance now. Zoom really opened that door for all of us. So there's
That's
lots
true.
of things, you can do a shared Google Calendar and be the person to call and set up doctor's appointments for somebody. So there's lots of pieces. So offer that, say, I can help with this and take this off your plate, or I'll do a Zoom with, you know, Bob, well, you give yourself 20 minutes to go in another room and read a book. Like I'm cool with doing that. So, there's lots of options to provide support, I think, from a distance.
Awesome. Thank you.
All right. We have a couple more online and we have a couple in the room here. Should we ever argue about politics or conspiracies?
No.
Avoid that as much as possible. I feel
Yeah.
like politics right now are almost delusional. Yeah, anything that you find that is like agitating or, anything, I think you want to, like one gentleman one time and they had like a news network that it doesn't even matter which one it was, but it was just on all the time. And I was like, I would be agitated if I looked
Yep.
at that all the time.
Yeah, when I worked at communities, we'd block, because you can put child safety
Right.
features, we'd block out all the news stations. That takes care of that issue. Don't have the newspaper come in the house. Like, there's ways to avoid all that stuff. So yeah, I would encourage that. Um, Why do some individuals with LBD fixate on negative behaviors on one particular person, often described as the closest person to them, and show time in front of others?
Can you repeat that? Sorry.
Yeah. So why do some people with Lewy body fixate on negative behaviors to their primary caregiver, their closest person, and then when they're in front of everybody else, they act like the world is wonderful and great and nothing's wrong?
Well, I think about it, you guys. I mean, as much as I hear you, and that is totally what we see, and I can only imagine how frustrating that is. We can all do that in a way, right? It's like we have that person that we're most comfortable with that will show our shadow side, as I call it. You know what I mean? The side that's I mean, my husband listens to my catastrophic thinking more than anyone. Everybody else thinks I'm just like good and fine, and everything. And then my husband knows how I can go down a rabbit hole like you can't imagine. And so I think it's that comfort level. And I think it really speaks to how they feel comfortable sharing that side with you, right? And then around other people, they feel like they have to act like everything's good. We kind of perform, right, for others. And so I think take it if you can as a compliment. And then it means that they're really comfortable showing that with you and expressing that with you and feel safe. I think we only share that side of ourselves with people we really feel most safe with.
It's kind of like you feel comfortable burping around some people. Same concept.
Exactly.
Be grateful that
Exactly.
they think that it's okay to do that. All right, last one online. FYI, one of the seminars I went to talked about the Parkinson's to dementia journey, described in layman's terms as this: consider the Lewy bodies as bugs that feed. When Parkinson's symptoms are the first to present, those bugs have started to feed on the motor neurons. When the dementia symptoms present, they start with the cognitive neurons. Eventually they get full or eat all of one and move on to the other. I really like that.
Yeah. Yeah.
That's great.
Absolutely. Very interesting. Thanks for sharing that.
Yeah. All right, you had a question, go ahead.
One was a medical term. It was the slowness in where they're processing information. Not bradykinesia is slowness in movement. It was, I think, slowness in where they're processing the information.
Yeah,
What's it?
bradyphrenia.
Phrenia. Okay, thank
Yeah.
you.
Yeah.
Never
So
heard that.
remember that. I don't know if you guys remember those old phrenologists. They used to have those heads that had the stuff on it, and it's like because it's like your head phrenology. So yeah, bradyphrenia.
Thank you.
Does anybody
You're
have any
welcome.
questions in the room? All right, well, this was wonderful questions. What a great group of people. Thank you all that are online and in the room, and for Julie joining us from LBDA. If you want to do any of the Insight programs, please feel free to go on our website. We have an event calendar. We're going to be partnering with Julia and her team quite a few times. We love working with them and getting the resources out to you. I will send an email out with the PowerPoint. And we just appreciate all of you and your patience. And the recording will probably be up by the end of this week. Okay.
Absolutely. Thank you.
Thank you
all.
all so much.
Thank
Bye.
you.